style question on rheumatic fever. Question: a 12-year-old boy presents to the clinic with complaints of joint pain, fever, and a new onset murmur. His mother reports that he had a sore throat about 3 weeks ago that resolved without treatment. On examination, he has a temperature of 38.5 degrees Celsius, 101.3 degrees Fahrenheit, and his heart exam reveals a blowing holosystolic murmur best heard at the apex. There are also erythematous, non-pruritic ring-like lesions on his trunk. Laboratory studies show an elevated ESR and anti-streptolacin O ASO titers. Which of the following best describes the underlying pathophysiology of this patient's condition? A. Direct bacterial invasion of cardiac tissue. B. Exotoxin-mediated endothelial damage. C. Immune-mediated cross-reactivity with host tissues. D. Superantigen stimulation of T cells. E. Deposition of circulating immune complexes. Answer: C means C. Immune-mediated cross-reactivity with host tissues. Explanation: this patient has acute rheumatic fever, a sequela of untreated or inadequately treated Group A streptococcus, gas pharyngitis. ARF occurs due to molecular mimicry, where antibodies against the M protein of Streptococcus pyogenes cross-react with self-antigens in the heart, joints, skin, and central nervous system. This immune response leads to inflammatory damage, manifesting as migratory polyarthritis, joints, carditis, mitral valve involvement, holosystolic murmur, subcutaneous nodules, erythema marginatum, non-pruritic ring-like rash, sydenham chorea, neurological involvement. This immune-mediated process is known as type 2 hypersensitivity, molecular mimicry, explaining why antibiotics prevent rheumatic fever but do not treat established carditis. Would you like a question on management